up front here, and then ask our question here at the microphone, okay? With that, Dr. Jackson, are you ready?
I'm ready. I'm ready.
Can everyone in this room hear Dr. Jackson okay? Oh my gosh, that is wonderful. Okay, go for it.
Awesome. Well, first of all, it's an honor to present. It's with deep regret that I'm not there in person. I needed to stay on the East Coast for family reasons, but just being there in spirit, it's a great honor, especially given the work that you're doing and the way that you're going about doing it. So a lot of my work is really focusing on sort of rethinking how we use the tools of epidemiology to study health disparities. And the reason that I focus on that is that I have a feeling or a belief that a lot of the tools that we are using have been developed to solve other problems. And so sometimes that may involve rethinking certain assumptions or rethinking the questions that are being asked. So that's sort of the approach that I take to a lot of my work. So today I'm going to talk about this paper, Meaningful Causal Decompositions in Health Equity Research. To allow time for questions, I'm probably going to fly through this material a lot at a lot quicker pace than I would usually do. But I really do want to leave time for questions. So I'm going to try to get through everything in half an hour. So please forgive me if I move too quickly. So a lot of the work that on decomposition, I think really spawns from the initial paper from Tyler and Whitney in 2014. And what I've sort of done is built upon it and expanded it and building in additional elements. And we're going to talk about sort of my most recent sort of view on it, which was just published last year. I've worked in a lot of areas. Currently, my K is funded by NHLBI, and my mentor works in hypertension control. But I think it's a really interesting and important problem because it's a precursor for cardiovascular disease, which is really a huge source of excess morbidity and mortality among racial and ethnic minorities. And you can see here that, over time, we have this huge gap in hypertension prevalences. I think this must be from the same paper the Whitney pulled from. These are data for adults over the age of 65. So we have this huge 20-point gap. And what you see here is like really shocking, but all too common is you see improvement in population health. So this is looking at hypertension control. Once you're treated, can you bring your hypertension control? So we've been able to improve that for all groups. But, when we compare non-Hispanic whites to who are in blue and Hispanics who are in yellow and blacks who are in green, we see that there are persistent gaps despite that improvement. And, I think this is a really classic scenario for a lot of health equity research, but one that's really striking because this is the area where we understand the epidemiology really well. We have a lot of non-pharmacological interventions. We have a lot of medications that have all been shown in rigorous studies to have meaningful impacts on hypertension control. And so, the challenge in really solving these issues is figuring out what can we do to actually reduce these disparities. It's really difficult because, and this is work from my mentor, Lisa Cooper, and colleagues out of the Johns Hopkins Center for Health Equity, is that the etiology of health disparities is very complex and involves factors at many different levels of societal organization. And so the state of the art in healthcare, we're thinking about reducing disparities in hypertension control. One approach, if you're thinking about patients who have this, who have hypertension, who we want to provide care for now. What do we do with this population? the state of the art is really to use or to develop a multi-level, a multi-component intervention. So that's an intervention that operates at different levels. So maybe it addresses the different targets, but it may do so through processes that occur at the individual level, at the family level, or at the provider level, or perhaps how care is organized, but they may be addressing many things simultaneously. So as one example of this, this is one trial that my mentor developed with Jill Marsteller. It's actually published in the American Heart Journal, and it's a cluster randomized trial that has does many things, and I'm not going to go into detail, but one of the things that it addresses is it addresses social needs by connecting individuals with community supports. It addresses goals that patients have and addresses barriers that they have in meeting them. So everything from adherence to diet to knowledge and patient activation. It also addresses things on the provider side, so the way that care is organized. It addresses many things at the same time, but this is the dilemma: is, you know, with these multi-level, multi-component organizations, multi-level, multi-component interventions, what things should they address, right? And I'm not even going to really answer the question of how they should be addressed, but what should they address? When you think about safety net clinics and you think about different institutions being able to implement these interventions with high fidelity, we have to select a finite set of targets that we think we can intervene on and address for this population. So decomposition analysis is one tool that I think is a nice synthesis of using the tools of epidemiology to do observational research to select targets that we think are implicated in disparity, obviously driven by upstream sources such as structural injustice and structural racism. But nonetheless, in this real life population, these targets need to be addressed. And so, causal decomposition is a way that I see as finding out those factors that are like Whitney talked about in her talk, that are, disparate among racial and ethnic marginalized groups, and asking, what if we change the distribution of those factors? And what makes it unique is that we bring in the best that we have in epidemiology, such as confounded control and ruling out alternate explanations. If you look back over the years, you would say that a lot of people have used observational studies and done regression analyses, to sort of identify these factors. But a lot of times, there's not careful attention to careful epidemiologic practice. And what can happen is that you can end up perhaps underestimating or overestimating how much these are truly associated with disparities. So just to, frame sort of, what's going to follow, I like to work from a concrete example. So this is an example where maybe I want to do a study. So I have, let's say I have good Kaiser data, maybe not the type of data I'm working with, where you've got, good records on everyone. Say we could enroll people at the time of their PCP visit. We might measure some things we want to adjust for, like covariates. We might want to get people who have hypertension. And then, we want to go for a period of follow-up to see if they can bring their hypertension under control. And then we might want to measure certain things at the time of the visit. So one thing that, we might look at is, do providers intensify treatment? Are there racial disparities in treatment intensification? And the going hypothesis in health services research is that, differences in treatment intensification, it really varies by locale. I mean, you'll see disparities in treatment intensification in some areas and not in others. But, it's really driven by, at least the theory says that it's driven by, it can be driven by poor patient-provider communication. It can be driven by patient-provider relationships that are not optimal in the sense that the patient is not well known. It can also be driven by implicit bias. It can also be driven by a lack of patient activation and actually being able to navigate that relationship. So there's many things that can go into it, but the output is that if the provider knows less about the patient, they may rely on stereotypes. So that's where the implicit bias or discrimination crops in. And so that's like the working hypothesis for treatment intensification. So I'm assuming that you guys know a lot about DAGs. So this is a cleaner DAG that I have in the paper. And I'm not going to go into what the arrows here mean in detail, but you know, X here is demographics. This is demographics. This is socioeconomic status, and this is clinical factors. So pre-existing conditions like diabetes and chronic kidney disease that may impact one's ability to control blood pressure. It's also their baseline blood pressure. And M here is our treatment intensification. R is race. And I know this is, not everyone may agree with this formulation, but I see that, you know, there are historical forces that serve to associate race with both demographics and socioeconomic status. And you know, I always think it's important to include this on the graph to really say that when when someone is born, there are certain correlates that are there already at birth. You know, there are certain associations that are there, certain disparities that are already present. And so to not put that on the graph is to sort of assume that, you know, things are sort of random at the outset, which they're not necessarily so. So if you don't understand anything else that I talk about, I think this is the main point of causal decomposition analysis, is I really think of it as a framework of population impact rather than mediation analysis. There are times that it aligns with mediation analysis and the estimators you get out of it, but I think at its heart, it's really asking a question about population impact. And what do I mean by that? I mean, is you look at, you know, you take populations as they are observed. And so I look at, you know, I look at the Black population. This is their observed process and their observed outcome for hypertension control, and the same for the white population. And so causal decomposition analysis really asks a hypothetical for the Black population. And in most of my work, I've focused on a really narrow intervention to remove disparities in a particular determinant of the outcome. So here I'm focusing on treatment intensification. And then you ask, you know, thinking about this notion of potential outcomes, what would be the expected hypertension control rate be for the Black population under this counterfactual? And so with that thought experiment leads us to sort of three estimates: the observed disparity, which is a contrast of the hypertension control rates for Blacks and whites; the reduced disparity, which is the contrast of the, observed and counterfactual scenarios for the Black population; and then the residual disparity, or how much would remain after an intervention, which contrasts the counterfactual hypertension control rate for Blacks versus the observed hypertension control rate for whites. And so if I just pause here, I think there are some important things. I know that, you know, Dr. Barnes is going to be talking about within group studies. And I think that, you know, that is really the essence of the reduced disparity, if you think about it closely, right? So like if I just had data on a marginalized population, you know, I don't necessarily need a comparison group to identify how much a disparity would change. I just need to take this Black population, estimate a counterfactual under an intervention, and the comparison of those two scenarios would give me an estimate of the reduced disparity. Another point here is that, you know, the interventions can be more general than what I'm going to talk about in this talk. So, you know, if you had in mind other interventions besides removing disparities in factors, so say there was some, exposure out there, or some protective factor that you wanted to increase, you could imagine those interventions, carry out your causal inference, and you can still estimate, this observed, reduced, and residual disparity. But what I'm going to talk about today is really about removing disparities in a particular target, because I think essentially that's what a lot of the interventions that I work in are sort of attempting to do, and I think it's an important question. So in order to do this work, though, I really was struck that I needed to step back and think about, well, what do I mean by disparity? So some of the things that Whitney was talking about earlier, and I also work from the Braveman, the Paula Braveman definitions, which informed the Healthy People 2020 report, and they define a disparity as systematic, plausibly avoidable differences that adversely affect socially disadvantaged groups, and they note that it may reflect disadvantage, but a causal link need not be demonstrated. And what they mean by that is that if you think about disparities from the perspective of human rights, the fact that a historically marginalized group is further disadvantaged on their on their health is morally problematic when you think about health as an essential good for well-being, and also its impact on many other goods that people may consider essential for well-being, including economic goods. So there's a moral argument that this descriptive measure of disparity is really salient enough without needing to establish a causal effect of race or racism or even social disadvantage. Those things may help, but it's not necessarily needed to think about these differences as morally problematic. There's another definition that is widely used in healthcare, which really has been applied in Benjamin LeCook's work and Alan Zaslavsky, and it's really the IOM definition that defines disparity in healthcare as differences that are not due to differences in access to care, clinical needs, or preferences to care. And you'll see I put asterisks there because one can debate whether or not they should be included or excluded from disparity. But I think the one that's not really negotiable is, clinical needs. And so we'll come back to that. But these are two major disparity definitions that are out there that I think have been widely adopted in medicine and public health. And so there's this notion of allowability that, a disparity or an inequity is not necessarily the same as an inequality, right? So there are some differences that we might think of as being unjust. We'll call those non-allowable. And then there are some differences that may be not necessarily contributing to unjust differences, or even ones that we might not think of as morally problematic. And so we would call those as allowable. And so, if you think about how, if we think about disparities in the outcome, when we're doing our thought experiment, disparities in hypertension control, question is, how do we think about differences in demographics, socioeconomic status, and pre-existing clinical conditions as contributing to disparities in hypertension control? And so I went back to the bioethics literature and some of the public health literature to really think about how are people thinking about these. And there's a lot of principles that but some of the ones that stood out are these two. There's one that's, I think, is shown up a lot in public health research without being named. It's this notion of manipulability. And by manipulability, I don't mean the manipulability of race. It's really that, there's these innate factors per se, and even if maybe not innate, but the time that a person is seen in care, if there's something that someone has no control over, right? So if the provider or the clinician has no control over, or if it's, say, a genetic SNP or variant that people couldn't change, the going with this principle, the sort of going rationale with this principle is that, those things wouldn't be necessarily considered unfair. And there's a counter argument to that, which I subscribe to, is that, even if, we can't change many factors, we can address their effects. And so you see that happen a lot in terms of clinical intervention. We have drugs, therapies that are tailored to age groups, that are tailored to certain genetic profiles. So, we can address different effects that are either of factors that are non-manipulable. But I make this point here is that I really firmly believe that, so in this case, under this principle, you would treat most things as non-allowable and include them towards disparity and not adjust. But I have a caveat that I usually work from, is that, I would want to adjust for these things if they don't disadvantage marginalized group. And so, like, what I mean by that is, like, if I think about demographics, usually in clinical samples, racial and ethnic minorities are usually younger and have a higher proportion of females. The reason why for that, has a long history, but the fact is, when you look at those samples, they'll be younger. And so that profile will predict better hypertension control. And so I usually adjust for them, because if I don't adjust for those, I might miss disparities stemming from other factors like SES and clinical conditions that are overrepresented, worse SES and higher rates of comorbidity that make hypertension control harder to achieve. I might miss those signals. In fact, there's a paper out of the Open Safety study where they looked at mortality differences across ethnic groups, and they saw that, in the crude difference, the crude ratio was null, but once you adjust it for age and sex, there's a twofold increase for ethnic minorities, and this was for COVID-19 mortality. And so, to me, that's a strong example of why it's important to, work from that caveat that you don't want to mask disparity. So I already talked about clinical SES and clinical status. Like, essentially these do disadvantage racial and ethnic minorities, and so are therefore part of disparity. I'm going to skip this. I'm going to skip this one, just out of interest of time. So, essentially, when I'm thinking about disparity, I'm thinking about a descriptive measure. You can have stratum specific disparity. So, like, you could have age specific and sex specific measures of difference, but a lot of times you want like a summary number. And so to get that, I'm just advocating that we do simple direct standardization, where we standardize, stratum-specific outcomes, differences in mean outcomes according to a common distribution of variables that we consider to be allowable. So in this case, age and sex. And this is not a causal measure. This is not an effect of changing this group's race to be that group. It's not even a causal effect of intervening to shift the distribution of age and sex. It's just simply a descriptive measure. So going back to the thought experiment, one thing with causal decomposition analysis is not just thinking about disparity in terms of outcomes, but we're removing disparities in targets. And this is, where it became crystal clear that, well, if we're going to talk about removing disparities in a target, we have to think about what does it mean for there to be a disparity in a target. So what does it mean for there to be a disparity in treatment intensification, right? Because again, the intervention that we have here is that we want to reduce disparities in treatment intensification. So should we try to, shift the rate of hypertension control so that there's no disparities, irrespective of any covariates, or is there something different that we would want to do? So I go back to this notion of of allowability, right? So a difference in treatment intensification may not necessarily be unjust. We want to hone in on what are the differences that we think are unjust, right? So allowable sources of difference might be things that we would want to adjust for. Non-allowable things are things that we would not want to adjust for to keep their contribution on the table. So again, with there may be many ways that race and treatment intensification are associated. That we see a racial difference that could be due to differences in age, socioeconomic status. It could be due to differences in pre-existing conditions and clinical factors. When you look at the IOM definition, actually, it really has this notion that clinical needs, right? So like we want to give healthcare equitably in response to clinical needs. And so it brings up this notion of a social contract. And so I was talking to some philosophers recently, and there are problems with social contracts because not everybody can agree to them. Most of the time, like even our Constitution, we all didn't agree to that. But I think of a social contract as an aspirational document, as that as an analyst, you could put forward what you believe society could agree to, based on certain values and norms, right? And so, I think of social contract as something that we could all ideally agree how a good should be distributed. And the criteria that govern how the good should be distributed are things that you would call as allowable. So, in the setting of treatment intensification, those decisions would be could be based on age and sex, because those are modifiers, clinical modifiers of treatment, clinical prognostic factors. Also, clinical status. We know that the ACC/AHA guidelines are stratified according to clinical conditions, but most guidelines are not going to include socioeconomic status as something that treatment decisions should be based on. And I think this is a very reasonable contract. And so I would say that a disparity in treatment intensification would adjust for demographics and also clinical factors, but not for socioeconomic status. And I'm just going to, you guys give me 8 more minutes, I'm going to fly through some things. But and I think this is true, even though we live in a society where it's very much true that treatment decisions are either directly or indirectly driven by socioeconomic status. So, again, this is, sort of an aspirational idea or contract. It doesn't necessarily have to be the one that is in practice in society. And the reason why I drive this home is that, when we go back to the types of interventions that Lisa Cooper would do and Jill Marsteller are doing when they talk to providers, to make clinical decisions, ideally those decisions are going to respect the clinical status and also clinical modifiers of treatment, and they wouldn't depend on one's socioeconomic status. So that's why this is important, because we're asking a very precise question. We want to remove disparities just like we would in our intervention. And in those interventions, the decisions are going to depend on age and sex and also clinical factors as well. So I'm going to skip this subtle point about the special cases where you have limited treatments, and that's a subtle point I bring up in the paper, but I'm going to skip it for now. So essentially, in causal decomposition analysis, it's an intervention to remove disparities and the target. And here, that's treatment intensification for those who have the same values of, say, age and sex, and also clinical factors. So these are both of these together are target allowable because they're used to define allowability in the target, whereas AY is you'll see is used to define the disparity. So that one's only outcome allowable. So our estimate here is, what would the hypertension control disparity be if hypertension control if the treatment intensification disparity was removed, right? So this is the disparity reduction. this is the, I have a lag. This is the residual disparity here, comparing that counterfactual scenario for Blacks versus the observed scenario for whites. And for those of you who are thinking about the formality of it, we're going to think of it as a stochastic intervention that really assigns the distribution of treatment intensification that's found among whites, uses that distribution to set the distribution for Blacks for those who have the same values of age and sex and clinical factors. So just to remove disparities in treatment intensification. So if we were to write this out, this would, AY would just be demographics, and then the intervention would depend on demographics and clinical factors. But what I'm really driving here is that the scientific question we're asking here has nothing to do with socioeconomic status. It doesn't define the disparity. I'm not getting into intersectionality, so please don't go down that rabbit hole. But for this right now, socioeconomic status doesn't define the disparity, and also doesn't define the intervention. Where it comes in is that we need to, just like in epidemiology, we have to rely on certain assumptions, right? So there are some, common support assumptions, some technical assumptions like positivity and consistency, but really the big one I want to emphasize is conditional exchangeability, which is unconfoundedness, and that's where a variable like socioeconomic status would come in, because in order to do causal inference here about shifting the distribution of treatment intensification, we have to be able to measure and adjust for all the confounders of treatment intensification, and that's going to include variables that we've deemed as allowable, but it's also going to include socioeconomic status as well. And so that's where it really enters the analysis, not in defining the disparity, not in defining the intervention, but analytically adjusting for confounding. And so if we have all of those assumptions, which I can come back to, we can identify, our counterfactual outcome for Blacks under this hypothetical distribution using this equation here, which I'm going to skip, but come back to if you guys really want to know the technical details of it. But essentially, we can estimate this guy through a weighting approach. There are other approaches that involve G computation. There's some doubly robust approaches, but essentially we can use inverse probability weighting, which is really straightforward. So we can estimate the disparity, the observed disparity, by comparing mean outcomes for Blacks versus whites using regular stabilized inverse probability weights. The catch is that the weights just adjust for age and sex for the outcome allowable covariates. So this achieves our direct standardization. To get to the reduced disparity, we can use a contrast of means for Blacks under two scenarios. One where they're weighted by this inverse probability weight that we described before, the stabilized inverse probability weight, and another where we're doing a ratio of mediator probability weight. And so we can estimate the numerator of that weight by fitting a model for treatment intensification among whites, given the allowables, and then we can estimate the denominator by fitting a regression model for treatment intensification, given the allowables, but also now the non-allowables. And so the model for the denominator is fit among Blacks, the model for the numerator is fit among whites, and you can think of what this weight is doing is replacing in the Black population this distribution with this distribution that's on top, and then we multiply this constructed weight times the stabilized inverse probability weight, and we can take a similar approach to get the reduced disparity. I'm about to wrap up, but what you'll find here is that this formula here actually reduces to many things in the literature, depending on what you choose as allowable or non-allowable. It's actually really cool. If you make certain choices, you'll end up with the same estimator that quantifies a natural indirect effect under much stronger assumptions. If you make certain choices, you'll end up with what's known as the Oaxaca blinder decomposition under linear models, and then under different choices under a weighting approach. And so the point here is that really, when you use those off-the-shelf estimators, they're making decisions about what's equitable versus not equitable for you. And sometimes I would argue that those automatic decisions that are being made for you are actually nonsensical, or at least may not respect the equity value judgments that you have in mind. So in this scenario, I'll just pick out the natural indirect effect analog. This is one that, you know, when you look at what's going on, it conditions it conditions the estimand and standardizes for all the confounders that you need to identify the effect of treatment intensification. So that includes demographics, socioeconomic status, and also clinical factors. But we said, number one, that, you know, SES and clinical factors were actually implicated in disparity. So that really violates, you know, this principle of amenability to intervention, because these are have worse profiles among the Black population. We can address them through our interventions. So we would want to include those in disparity. It also violates the principles of social contract, because by conditioning everything on all of the covariates, the intervention to remove disparities in treatment intensification depends not only on demographics and clinical factors, but also on SES. And so it's an inequitable intervention. So I'm going to end there so we have time for questions. Thank you. I'm sorry I had to go through it so quickly, but I wanted to have time to discuss.
John, that was wonderful. Thank you so much. Can you hear me?
Should I? Yeah. Should I stop sharing or should I keep it up?
Yeah, go ahead and stop sharing.
Okay.
So I want to congratulate you on a talk that had formulas in it that I could follow. So it was really great.
Thank you.
And I followed about 95% of it. So that's saying something.
That's awesome.
So
that's awesome.
Yeah, what we do, we have about 10 minutes for questions. We need to skip our break because Dr. Barnes needs to give her talk at that time. So if you need to stretch, if you need to have a bodily function break, whatever it may be, go ahead and do that on your own. Okay, we're going to have to do that on our own. In the meantime, let's get some questions going. Ryan, so the people who are in the room, you need to come up here to this mic to ask your question. So Ryan's coming around. And John, maybe you can prep your answers to me, because during the talk, I put some questions in the chat.
Okay.
Come on up, Ryan.
Yeah. Okay. Yeah.
Hi, John. Great talk. I only have technical questions for you.
Okay.
I guess
okay.
A broader question is, so Vanessa Diles and I pointed out that interventional effects, you're not quite free to choose the interventional distribution, and you might get cases where the total effect is not the sum of the indirect and natural effect like you would think. Does your approach also suffer from that sort of thing? And also,
go ahead. Go ahead.
And Caleb Miles also pointed out that these stochastic effects also do not respect the sharp null, so that you have no indirect effect for anyone in the population, and yet you'll get an average indirect effect. So does that also apply here?
Yeah, thank you, Brian, so much. First of all, I love your paper. Second, I think your answer or your question is really why I don't see these things as mediations. I really work under the framework of population impact, which was first put forward or published by Hal Morgenstern, I believe back in the 80s or 90s. There's really this concept of you have an observed population, you imagine in intervention, and then you compare the before and after. And the most, I think, simple example is the notion of the population attributable risk, right? And so I'm not asking questions about total effects of manipulating race. I'm not trying to approximate that at all. I'm really just asking, if we have these different groups and we intervene on them in certain ways, how does that change the descriptive measure of disparity? And so the limitations that you pointed out are limitations that occur when you try to interpret what's going on here as mediation. But there's no reason normatively or morally why I think that they need to be interpreted as mediation. I think in some frameworks you could go down that road and arrive at certain answers, but in this framework it's not necessary. And that's why I opened up with those definitions of disparity, to really show that what we are really targeting are estimates that really have a moral grounding, and that we don't necessarily need to interpret as mediation. I think the notion of population impact is probably what we have in mind anyway. So I hope that answers your question. But really, those are limitations of a different method.
Okay, sorry. I wanted to tell you that Ryan's giving a thumbs up, which is good.
Oh, okay. Okay, good.
So Ganga Bay is going to ask the next question. I would love for you to see us, but our connection gets a little wonky when the camera's on, so I turned it off.
That's fine.
Hi, John. Thank you so much for the wonderful talk. You mentioned not getting into intersectionality, so I'm not even going to go there. I'm not going to even do that to you. But I do want to, I wonder what your thoughts are on potential dangers of this conceptualization. So I'm thinking about, like, what if somebody chooses to do like decomposition analysis to examine like income intervention on violence in Chicago neighborhoods, and they find that the intervention doesn't really reduce like deaths from violent deaths among young Black men, but community work shows that giving people a little bit of money really goes a long way. I'm wondering, how do you think, are there potential inconsistencies with using the statistical method to assess this versus the on the ground work that kind of pulls in much more of the, I'm not saying much more, but is grappling with the social constraints?
Yeah, no, I hear you. Like, I hear what you are getting at. And I think it's a limitation of not just this work, but all of what we typically do in epidemiology is, a lot of the exposures that we study are driven by social forces that are dynamic, interdependent, and mutually constituted. And so, and we also know that many times after you intervene, the DAG changes, right? So, like you come in with your intervention and all of a sudden another barrier pops up that didn't really exist before. So I sort of argue in a commentary that I have that, doing this sort of work is really the first step, but you really have to kind of integrate it with more qualitative work. That's like actually my dream, is that people would do this with a mixed methods study where you actually engage marginalized groups and sort of flush out what are the barriers and how are they, what are the things that are actually driving this risk factor distribution. I think that the limitation that you raise is an important one, but I think it's something that, like, if you really think about it, is really like an Achilles heel of a lot of what we do, even effects of social policies. A lot of what we have today is sort of what we can observe, and we can't really predict very well, especially in the setting of health equity, how things will change if we intervene. And that's because the world necessarily changes in response. And I don't really have a good answer for that, except that, you have to really try to ground your results in the broader context of what's going on, what's driving those factors. And so it's not really a reductionist view. But I think you have to take a broader perspective when you're doing this work. But I take your criticism and question to heart. I mean, it's a very real issue that, I don't think that, more analytics will solve. I think it's something that you have to really step out and engage with people who are doing more conceptual and theoretical and also activist work to really, for the results to be useful.
John, you have a lot of amens and head nods and snaps in the audience for that.
Okay.
And here's Dr. Robinson.
Uh-oh.
We're all friends. I loved this paper. I hadn't read this paper before, so that's a good thing about going to a conference with like a reading list. And I really loved it. I love the way it bridges like the causal inference piece with like philosophical questions, really, about like, how should we think about these issues? How should we decide what to study and, what we just accept versus what we try to intervene on? And it made me think about training, like to really implement something like this, you have to train people to kind of make some value judgments. I mean, you can use something like the IOM definition that kind of gives you value judgments, but then you're also skeptical of that. And I think rightfully so. Like, how does this impact how you train people, how you think we train people, if we're going to try to adopt this framework that integrates kind of the causal inference and these value judgments into our models explicitly?
Yeah.
Value judgments are always already there, but you getting explicit about them is really nice.
Yeah, I love this question, and it's really hard. I mean, the big question is, how do I train myself first? I mean, there's, I've been spending a lot more time reading ethical frameworks, reading philosophy, reading theories for distributive justice, and it's difficult because you go in there and you find there's a lot of arguments there, right? So there's a lot of unsolved things. I mean, you have frameworks like Rawls, who assumes like an ideal world, which has a lot of problems. Then you have people like Madison and Powers, who are really operating from a structural injustice framework, and you have others like Amartya Sen, who are thinking about people with like very particular cases that are often left out, like people with disability who may not be able to take advantage of everything. I think that the field of health equity has often sort of maybe left engagement with this material to the experts, and I think that's not necessarily for the best. I think there should be space in our curricula to read through some of these frameworks and think about what are their benefits and what are their limitations. Not that they'll give you a ready-made answer for what should be allowable, but they'll give you a way of thinking about allowability in a particular context. And these frameworks talk about much more than just what's allowable versus non-allowable, but they really do help you see a lot of the implicit values that are baked into the ways that we define outcomes, or the ways we consider what's possible, or the ways that we consider what's fair. And so I think, I really do believe that, it would be nice to have either a special seminar where we can sort of build this into some of our social epi training, because I was really surprised to see in the public health literature that, these frameworks aren't really discussed or taught at all outside of bioethics per se.
That's cool. You should send your reading list to Jen.
Yeah.
Oh yeah. We can read together.
So John, I just want to thank you so much for your time. We know you have a busy, schedule, that you're going to be with us later in the week.
Yeah.
So John's going to be around at selected times during the week, and I'll pass that on to you. If you could email me your slides, it could be in, PDF version or whatever. And I will share those around, because I saw a lot of people taking pictures of the screen here to your DAGs and things like that. So we need your slides.
Of course.
And that's it. Thank you. So, your reading list, right? So the reading list that you just talked about with Whitney, that's going to be incredible. So thank you so much again for your time. and for an amazing talk.
Oh, thank you. Thank you. It's been an honor. I mean, just like, yeah, I'll say that and move on. So Dr. Barnes